All right, well, thank you everybody for coming. So for those of you who I haven't met, I'm Dr. Miller. So just a little bit about my background and we'll get started with our talk. So I'm a general surgeon, so I do all kinds of surgery, but mostly minimally invasive and robotic surgery. I was a surgeon in the Army for about 12 years, and I got out of the Army last January and joined the team here, so I've been here just about a year. So as I mentioned, I do mostly minimally invasive robotic surgery and a lot of weight loss surgery as well. So with that experience, I've operated on the stomach quite a bit throughout my career, and that's kind of led me to my interest in reflux. And kind of as you can see by the crowd in this room, reflux is a major problem. Okay, so with that, we'll get started with our talk. So first of all, I don't have much to disclose. Some of the slides that I got here tonight are from the company that makes the device that I use for my reflux procedures. I don't get paid from the company, fortunately or unfortunately, so I choose to use their equipment because I like how it works, but I don't get any money for using their device or for recommending their surgery. So if I'm recommending a procedure or surgery, it's because I feel like it's the correct procedure or surgery for you, and not because I'm getting paid by some company. All right, so again, no conflict of interest. This is purely informational. It's just so that you have an idea of what kind of options that we're starting to offer here at Lakeland for reflux. So we're going to talk about GERD. We'll start with kind of real simple, what is GERD, and kind of move on to different treatment options. And there's something I'd emphasize is there's a range of treatment options, okay, ranging from changes in your lifestyle to starting medications to surgical procedures. And what we're going to talk about a little bit more here is kind of some of the more newer, less invasive, but effective procedures that might be alternatives to some of the other medications or surgeries that we have in the past. And then we'll kind of move on to what the next steps may be for you. So reflux is basically when the contents of the stomach, so the acid that's produced in the stomach, gets up into the esophagus. Now that's kind of a normal occurrence that you get some stomach acid from the stomach into the esophagus, but when it starts to develop symptoms, or when it starts to cause symptoms, or when you start to develop irritation or injury to the esophagus, that's when we call it gastroesophageal reflux disease, or GERD. All right, so the typical symptoms of reflux or GERD, the biggest one is heartburn. So like that burning sensation kind of in the upper part of your abdomen or lower part of your chest. That's kind of a typical symptom. Other things can be chest pain. Frequently, patients will go to the ER and they'll be evaluated to see if they have they're having a heart attack, and it turns out, no, they just got real bad reflux. So that's actually a pretty typical scenario. Excessive salivation, so producing lots of saliva, that's also a pretty common scenario. Having regurgitation, or that sensation that, you know, kind of that bile output from your stomach is coming up into the back of your throat, kind of acid taste in the back of your throat. Those are pretty typical symptoms. Trouble sleeping, that's another pretty typical symptom. So a lot of patients will describe lying down is usually the worst. So they'll wake up in the middle of the night and have symptoms of acid in the back of their throat. Sometimes it gets pretty severe and it can cause things like vomiting in the middle of the night. That's a fairly common one that I see. So in addition to these common symptoms that I would assume a lot of people here in this room might have, there's also some atypical symptoms. So these would be things like persistent coughing. So one of the reasons for a patient with a chronic cough may be that they're refluxing, irritating the back of the throat with their acid reflux, and that causes a coughing. Frequent or difficulty swallowing. So over time, a bunch of acid in your esophagus is not a good thing, and that can develop problems with the swallowing mechanism. So that's another uncommon or atypical symptom, but certainly can happen with reflux. Then there's a few other things that are a little bit more unusual. Dental erosion. So I have had patients been referred to me from their dentist because they have these erosions in the back of their teeth that's from high acid exposure that just hasn't been diagnosed. So those are some of the other atypical symptoms that you can see. So reflux is actually a pretty complicated thing. It seems like it's pretty simple. Oh, your stomach acid is not where it's supposed to be. It's coming up to the esophagus too much and it's causing problems. But kind of the more we research and study this, the more complicated it gets. So when we look at the whole reflux picture, we're basically looking at three fundamental things as we go through. So the first would be the esophagus, and that's what we'd call the pump. Okay? So the esophagus is that tubular structure that goes from your mouth down to your stomach. And I think in the past it's been thought of, well, it's just a big tube, what's the big deal? And it's actually a pretty sophisticated organ. It's made of multiple muscle layers, and it peristalsis, so it squeezes the food down. So that's why we call the esophagus the pump. It pumps food down. It's assisted by gravity, so when we're standing up, it helps food go down. It's also assisted by saliva to kind of lubricate things as the food bolus goes down. But the esophagus is basically the pump that brings food from the mouth down into the stomach. Now the next component of reflux is probably the most complicated, and that's where I focus most of my time on, and that's the valve. So that's the junction, or basically the connection between the esophagus and that stomach. That transition point between where the food comes down to the esophagus until it gets into the stomach. And that's what's called the gastroesophageal valve. Now, we call it a valve, but it's not a true valve. A true valve, if you close the valve, it stays closed. We don't have a true valve. We have components that sort of make a valve, but that's why, you remember how I said at the beginning that some reflux is normal. It's only when it causes symptoms or damage that it's considered a disease. Well, that's partly because it's not a true valve. It's not like food just goes down and the door shuts. There's still kind of a possibility for one of the mechanisms to be open. So it's best thought of as kind of more of a doorway, maybe, than a valve, and it's kind of a swinging door, okay? So, and then finally, the reservoir is the stomach. So sometimes the problem with reflux isn't as much as the pump, the esophagus, or the valve, that gastroesophageal valve. It can be that the stomach isn't emptying as well as it should. And so when we're dealing with reflux, especially when we start to get to the point where we're thinking about doing a procedure for reflux, it's important to understand how each of these individual components are working before we can say what the most appropriate treatment option might be. Okay, so what prevents reflux? So this is a picture of the esophagus going down and entering into the stomach. And what you see is the diaphragm is that muscular structure that sits around the esophagus. Okay? So there's a couple of different things, a couple of different components that help keep food and gastric contents, stomach contents, into the stomach. One is the length of the esophagus below where this diaphragm pinches it closed. So obviously there's an opening there. It doesn't pinch it closed all the way, but it does provide a little pressure to keep a little support for things generally staying down and not going up as much. Okay? There's also thickening of the muscles of the esophagus, which help to keep food and gastric contents down. And there's an angling of the esophagus that helps keep the stomach contents in the stomach and from getting into the esophagus. So from a surgery standpoint, understanding this anatomy is very important because there can be variations that on each of these components that can make reflux more likely or less likely. Okay? The other thing to remember is the pressure in the abdomen, so the pressure below the diaphragm, so in your stomach area, is going to be higher than the pressure in your chest. So if you think about it, that kind of makes sense if you think about breathing, right? So when you take a breath in, the pressure in your chest and your lungs is actually lower than the pressure outside in the atmosphere, and that brings air in. So the pressure in your chest is lower than below the diaphragm in your abdominal cavity. Okay? So that pressure will help pinch this esophagus closed if it's in the right spot. But as you'll see in the next sets of slides, that if the esophagus isn't in the right spot, that pressure in the abdomen might be pushing things up instead of helping to keep things closed and down where they're supposed to be. Okay, so I don't know how many people have heard of a hiatal hernia, but it's a very common entity. and it's where the stomach slides above the diaphragm. Okay? Oftentimes it'll go up and come down. It can occur from a number of different reasons. Sometimes it can be congenital, so you're born with it. Sometimes it can be from a trauma where you had a hit to the stomach and it pushed the stomach through your diaphragm. And sometimes it could just happen over time, as the diaphragm might just be a little weaker and have a wider opening where there's a space for the stomach can push up above the diaphragm. So it can happen for a number of different reasons, but if you think back to the picture we just showed, if you can imagine the stomach is a little bit above the diaphragm, that pressure in the abdomen is pushing up, and any stomach contents that would be above that diaphragm have a tendency to go upward instead of downward like they're supposed to. So, well, yes?
So is the hernia into the esophagus then?
So the hernia is the stomach going up where the esophagus should be.
So it's moving the esophagus.
Yeah, it's displacing the esophagus upwards, right? So it's pushing things up, and that can worsen reflux because more things can reflux up. All right, so when we're addressing reflux, when we're talking about GERD, there's a lot of different options, and not any one option is going to be necessarily the same for two patients. So there's several different roads that people can take. The first would be lifestyle modifications. And we'll talk about that in the next slide. The different things that you can do to kind of try to change behavioral habits, change your lifestyle so that you can avoid some of those reflux symptoms. The next path would be kind of medications. Okay, the lifestyle modifications didn't work, and so you try medications to decrease the stomach acid or neutralize stomach acid to see if that helps with symptoms. And then kind of the third branch would be, well, should we get a procedure? And part of that branch is, well, we need to evaluate what's happening in your esophagus and stomach and figure out why you're refluxing, why you're having symptoms, to see if we could do a procedure to fix the problem rather than taking medications or just doing lifestyle modifications. So when I talk about lifestyle modifications, the biggest one on here and the first thing on here is to lose weight. So remember I talked about the increased pressure in the abdomen? Well, if you gain weight and have increased pressure in the abdomen, that's going to make it more likely that your abdomen pushes things up and you have more reflux. So losing weight is probably the number one thing that you can do to help prevent reflux. All right, probably the next thing after that is sleeping with your head of bed elevated, especially for patients who have worsening reflux when they lie down. Sleeping with the head of bed elevated is kind of an easy tool that you can use to help minimize some of your symptoms. Now, sometimes this confuses patients because they think, well, I sleep with 3 pillows, so my head's elevated. But what that can do is kind of bend your abdomen, crunch your abdomen, and that can actually make your reflux worse in some cases. So when we say sleep with the head of bed elevated, we mean elevate your bed so that you're sleeping on an incline. Does that kind of make sense? So you're not bent, you're still flat, but you're resting kind of up so that gravity is helping to keep any of the reflux down. Okay? Then there's certain foods, and a lot of people can relate to this. And they're like, well, I'm okay unless I have that spicy pizza before bedtime. Okay, so avoiding trigger foods. So coffee and tea, things that have caffeine, sodas, they can be trigger foods. Certainly tomato-based foods are common for worsening reflux, so avoiding some of those can be helpful. Not all the time, but they certainly can be. Eating smaller meals and avoiding eating too close to bedtime, that's probably another very important one. So if you give yourself at least 3 to 4 hours where you finish dinner and have 3 or 4 hours before you lie down and go to bed, that can usually help because that gives you time to empty out your stomach and make you less likely to reflux at night. And then avoiding things like alcohol and tobacco products, which can also increase secretion of acid and increase reflux. All right, so whenever someone comes into a doctor's office with reflux, those lifestyle modifications are generally what we tell patients. And sometimes it's helpful if you haven't been trying those things. And a lot of times it's not, because either you've already been trying them and it's not successful, or it's just a little bit too difficult to make all those lifestyle changes because of other things that are happening in your life. Okay. Hopefully your life doesn't revolve around reflux, but in a lot of cases it kind of does. Okay. You have to make a lot of changes for the reflux, and so that can be a factor for why patients go on medications rather than just lifestyle medications. And certainly as the disease progresses, it's why many people choose a procedure as opposed to sticking with the medications that can be hard to control the symptoms. Okay, so for medications, we actually have several very good medications. They have their positive effects, and they also have their drawbacks, like anything else in medicine or anything else in life. They have their pros and their cons. So the first kind of group of medications are just antacids. And these are basically medications that neutralize the stomach acid. Okay, so these would be helpful in general for patients with mild reflux who have very intermittent symptoms. So maybe once a week they have some heartburn, and they'll take a Rolade or something like that and feel, or Tums, and they'll feel better. And then we have our next group, which are called H2 blocker, or the histamine receptor blockers. And these are very effective at reducing stomach acid. And these would be, in a lot of cases, the next go-to for limiting the amount of acid that's produced in the stomach. And then finally, the most effective group of medications are what we call PPIs, or proton pump inhibitors. And these are medications like Prilosec, Nexium, Dexilant. So these are very effective medications at reducing the stomach acid. But they do have their side effects in the short term, but more significantly in the long term. They're kind of the more aggressive medications in terms of reducing acid. Normally when we prescribe these, we recommend that they're given for a period of time, and then that we phase them out, meaning that we try lifestyle modifications and then try to convert back over to H2 blockers and then hopefully off medications. But what frequently happens is patients aren't able to get off of their PPIs because they're still having symptoms when they try to come off of them. So a lot of the side effects are starting to make headlines and in the news. I know Zantac came out and was coming off the market. That actually didn't have to do with the medication itself. It had to do with a component that was in the medication. So we can't really blame that so much on Zantac. That medication is actually okay. It's just how it's manufactured. It was produced with a carcinogen, so thankfully they halted that. But long-term use with medications like Nexium and Omeprazole, there are some concerns, especially for some of the things that are listed here. Now, some of these concerns are legitimate, and some of them are probably a little bit overblown. Like anyone who's ever seen one of those pharmacy commercials, you can see that the list of potential side effects is a whole long list that they rattle off real quickly. So how likely are you to have these symptoms? It's a little bit hard to say. But without producing stomach acid, some of the things that we do find very concerning are things like developing anemia, because you're not getting enough iron absorption because you don't have enough stomach acid. Things like osteoporosis because of calcium and vitamin D deficiencies related to not breaking down foods and absorbing them enough. There's a few other things on there, like increased risk for pneumonia. And actually we've seen an uptrend in patients, especially over the age of 65, who are wanting surgery because of concerns for dementia with PPIs. As I said, there's some evidence to support these long-term side effects. There's some other larger studies that show that they're less of a concern. So in some patients, being on a long-term proton pump inhibitor may be appropriate, but the point of this slide isn't to scare you off of your medications. The point is to let you know there are some long-term concerns, and we have to kind of weigh the risks and benefits of staying on a medication. Yeah?
You didn't mention a side effect that I've heard of recently is stomach cancer if you're on it for a long time. Have you heard of that?
Yeah. What I would say is that's certainly been a concern of surgeons for a while, mostly because we've done surgeries that affect the nerves to the stomach that reduce stomach acid. And those are surgeries that have been done, decades in the past, but what are the long-term concerns about reducing all the stomach acid? So this is back in the era of having ulcers. Now we have medications that prevent the ulcers, actually the proton pump inhibitors. But when we would do surgery to cut the nerves to the stomach so it wouldn't produce stomach acid, we did see an increase in cancers. Now, having said that, we don't have the literature to prove an increase in cancer with these medications, but that is a concern. We do see the rate of gastric and esophageal cancers rising. It's hard to, I can't tell you based on just the literature that that's because of the medications, but that, whenever we're involved in treating patients, either with medications or procedures, we have to consider the long-term ramifications as well as the short-term, and so those are things that need to be studied and further evaluated. But what I would say is that we don't have, I can't tell you definitively one way or the other, but it is a concern that needs to be studied. Okay, we need to be vigilant on what we're, we can't just say, oh, this is the magic pill, it cures everything. We need to kind of see what the long-term results are. Just the same way we study the surgeries that we do, we need to evaluate what the long-term results are. So, okay, so the medications are effective, but they have potential side effects, and you have to take them, and some people just don't want to take all the medications. Over time, the medications may not stay effective, and those are kind of really the patients that we would consider a procedure on, because if you had the medication, it was initially effective, and then over time was less effective, then that's kind of the group of patients that maybe it's time to start thinking about a procedure. But one of the other things that is a downside to the medications is, remember we talked about the pump, and then we talked about the valve, and we talked about the reservoir. It doesn't do anything for the pump. It doesn't do anything for the valve. It sort of does something for the reservoir in that it just decreases the stomach acid. So all the medications just deal with the acid. They don't fix a hiatal hernia. They don't change how the stomach is laying in the abdomen. They don't bring the stomach down into the abdominal cavity where it should be. They just decrease the stomach acid. So you're still refluxing, you're just not having the symptoms from it because it's no longer as acidic. All right, so we're looking at treatment. The doctors will be looking at, okay, here's some subjective improvements. So we want to look at quality of life scores. We want to see, is there improvement in inflammation of the esophagus? We want to see, is the patient satisfied? We want to see, does the treatment last long? Is it durable? And then we want to see all these objective improvements in how the esophagus looks on endoscopy. Meanwhile, when most of the patients come in, they want to, like they says here, I wish I could feel normal again, or I need a decent night's sleep. So a lot of times the mindset of the physician is very different than the mindset of a patient. Most patients come in, they just want to feel better, okay? It may not matter to them as much how much inflammation of the esophagus they're having or not. It's how much of a pain they're having from the inflammation or lack thereof, right? So a lot of patients they want to improve their lifestyle. They don't want to deal with the symptoms, or they don't want to deal with the medications, and they're trying to see, is there a better option? And so I think it's important, especially from the nerdy physicians on one side, to kind of think about how this impacts people's daily lives and kind of what they have to go through in dealing with these kinds of problems. So there's about 6.7 million people who have uncontrolled GERD in the U.S., but about less than 30,000 elect to have surgery. So what you see in this chart is for patients with mild disease, meaning you only have a few episodes of heartburn, maybe once or twice a week, if you stay away from the pizza late at night, or if you don't eat too close to bedtime, you do okay. That's going to be probably the majority of the patients. And for those patients, we just recommend lifestyle changes. Lose some weight, change some of your eating habits, and you'll be okay. For patients with more, moderate symptoms, like the heartburn happens more frequently, it's a little bit more of a nuisance, it impacts their life a little bit more. For those patients, we tend to recommend medication, and especially in the past, it's only been the severe patients, so if they have horrible symptoms, they're vomiting every night after they lie down, a few hours after they lie down. Those are the patients that we look at to doing surgery because it's invasive, it requires a surgery, and there can be complications or side effects from the surgery. So what I'm going to talk about a little bit more tonight is kind of an in-between option, and that's the TIF procedure. And what our goal is for this is to add some more treatment options to our armamentarium dealing with GERD. So instead of it being kind of a lifestyle and medications all on this side and surgery for a very few, we're trying to expand the group of patients who have moderate to severe symptoms, who are unhappy with just medication and lifestyle changes, who want to find something else to tackle the reflux symptoms that they're having. So we're really trying to just expand the group of patients that we can help through procedures who aren't being adequately treated just by medications and lifestyle. So with that in mind, what we're really targeting is the valve, the gastroesophageal valve. What we want to do is fix the mechanism so that as things travel through the esophagus and go into the stomach, they stay down the stomach and don't come back up. So that's our main kind of target when we're doing these procedures. So it may be a little bit tough to see from the back, but when you look at what a normal stomach looks like, so when I put a scope in and I look back at the stomach, what a normal stomach looks like as I look up at the esophagus. And normally when I look back up at the esophagus, I don't see the esophagus because the stomach is kind of closed up around the top of the scope that I'm looking at. So that's what you can see in this picture. It might be a little tough to see from the back, but this is just a folded stomach kind of wrapping around the scope. So that black little thing is a scope that came down. I'm looking back on it. The stomach is wrapped nice and snug around it. For a patient who has what we call an incompetent valve, it's loose around, and it might be hard to see, but it doesn't fit snugly around the scope. It's kind of loose and floppy. And actually, if I move the scope around, I can look all the way up the esophagus because there's nothing in between. It's just kind of an open, pathway for anything to reflux back up. So that's what we're targeting. That's what we're going to try to fix with these procedures. So in order to know if a procedure is appropriate for the patients, it requires a great deal of information, which means it requires lots of tests and a big workup. So probably the first thing I do is what's called an EGD, or an upper endoscopy. So I take a camera on a scope, put it down into your esophagus, look at your stomach. Okay, that's kind of step number one. And that tells me a few things. It tells me if there's inflammation of your esophagus. It tells me if you have a hiatal hernia. So again, that was where the stomach pushes up above the diaphragm. It tells me if there's any other abnormalities that might be explaining some of your symptoms. It allows me to look and see, do I see anything refluxing back up into the esophagus? So that's kind of the starting point. It also allows me to take biopsies. So if I do see inflammation, then I can check for any damage to the esophagus. And so what can happen is when you get inflammation of the esophagus, the cells of the esophagus, so the lining of the esophagus, can stop looking like esophagus and start looking more like stomach. So the cells start transforming because they see so much acid, they think, oh, I'm not an esophageal cell, I'm a stomach cell. And they change into a different type of cell. What's called metaplasia. So the esophagus starts turning and looking more like stomach. Well, why is that a problem? It's called Barrett's esophagus. Now that's a problem because as the cells start changing, they don't just necessarily stop at turning into stomach cells, they turn into what we call dysplastic cells, so you get dysplasia. And why is that important? Well, that's one step short of cancer. Okay? So damage over time causes changes in the cells that lead to cancer. Okay? And that's something that I'd look for and detect on upper endoscopy, and that's where we'd start. Okay? Another test that I do is what's called the barium esophagram. That's when you drink contrast or barium. And what that shows me is kind of a broad strokes. What's the roadmap? How does the esophagus look? How does the stomach look? If you have a hiatal hernia, this will also show it. It gives me some idea of the function of the esophagus, how well the esophagus empties out into the stomach. And it also gives me some idea of how well the stomach empties, to see if part of the problem is that the stomach is the problem, not emptying, and that causes the reflux, or if it's something else higher up with the valve or the esophagus. So that would be the next step. And then a third step is what we call pH testing, and I do this at the same time as the upper endoscopy. So again, it's a lot of different tests because we need to know a lot of different things about the esophagus and the stomach. So what the pH testing does is I put a little capsule in the esophagus that measures the acidity of the esophagus. So this tells me how often you're refluxing acid, how severe it is, and it also tells me how well it's correlating with your symptoms. So if you're having heartburn, I can see on the tracings of the recording that, yeah, you were having reflux and then you had heartburn. But if you're having heartburn and you're not having acid reflux, then we need to figure out if maybe your heartburn isn't maybe just your heart. Okay? So it tells me exactly how much acid is being exposed to the esophagus, and that's an important thing to note because if we're trying to fix the problem of minimizing the amount of acid that gets from the stomach into the esophagus, we should kind of quantify, well, how much acid is getting into the esophagus. So that would be another test to do before we do procedure. And then finally, I'm talking about fixing the valve. So it's important to know if that pump, the esophagus, can pump food through the valve if I tighten it up. So the last test we do is what's called a manometry, where I test to see how well does that pump work? How well does the esophagus squeeze to push things into the stomach? Okay, because what you'll see is as we tighten up that valve, we need to make sure that the pump can push things through the valve like it's supposed to. All right, so surgery for reflux in the past has almost been exclusively wrapping the top part of the stomach around the esophagus, doing what we call a Nissen Fundoplication. So Nissen was the name of the surgeon. Fundoplication is the actual name of the procedure because it's the fundus, the top part of the stomach, that we're wrapping around the esophagus, or we're plicating around the esophagus. And so that's what this picture is showing. This is a stomach. It's wrapped around the esophagus, and it's tied to itself. So that's creating a constriction around the esophagus that helps kind of create a valve. So this operation works really, really well at preventing things from coming up out of the stomach into the esophagus. Okay. The downside to this operation is that it works really, really, really well, meaning that sometimes things that you might want to come up out of the stomach, like gas. Okay, so if you're not able to belch, that doesn't seem like a big problem until you're actually not able to belch, and your stomach gets full of air and can become distended and can become painful. The other problem is it might work a little too well in that it's too tight, and that food can get stuck in the esophagus before it can get down to the stomach. We call it dysphagia. So food getting stuck was another problem. So again, can in some cases work too well. Now, most patients that are appropriately selected have good results with the fundoplication, but over time, this can also break down and may not be a permanent solution, but it is a very good operation. It's very effective. But because it requires surgery, which requires incisions, and because it has some of those side effects and those downsides, we tend to reserve this operation for people with very severe disease, very severe reflux, and we don't just offer it to anyone on the street, which is why even though there's, what, 6 or 7 million people with uncontrolled reflux, only about 30,000 are getting the procedure because they hear about some of the side effects and they say, no thanks, I'll just take my pills. Okay. So, you know, we kind of went over the Nissen, and for a long time it was like, well, this is what we got. It's pretty good. It's not perfect. And then so everybody else just get medication. Well, the TIF procedure is what's called the transoral incisionless fundoplication. And so I'll show you some pictures of what we're doing with this procedure. But as we're talking about this, just keep in mind what we're trying to do is fix the problem with the valve without kind of over fixing it, right? We don't want to over correct the problem. And we're trying to do the least invasive procedure that we can. So we're trying to lower the risk and optimize the effectiveness of the procedure. And so that's kind of where the TIF procedure comes in. So what we do with the TIF procedure is it's done through the mouth, so it's transoral, meaning through the mouth, and we put a scope in through the mouth along with the device. And what you see in the black here is this is the camera watching the device as we perform the fundoplication. So it's similar to the surgery in that it's kind of recreating a valve. So what happens is with this device we pull some of the esophageal and stomach tissue together to make a valve. And that's kind of what you see in this picture here. We're just making a valve from the inside that helps prevent contents from the stomach from refluxing back up. Okay? So it's all done through the mouth with this procedure, no incisions, and it creates an effective barrier to reflux without some of the side effects of dysphagia where the food gets stuck. You could expect to still be able to belch, or if you had to, vomit after the procedure, because it's not overly constrictive. It's just creating a valve, and it's all doing it through the mouth without any incisions. So this is a picture kind of comparing the two options. So this is the old Nissen Fundoplication, where it's a surgery where we wrap the stomach around. And this top picture is actually what it looks like when we do the TIF procedure. So we're creating kind of a partial wrap. We're creating that valve, but it doesn't wrap all the way around. And actually, when you look at it from the inside with the scope, it looks kind of what a normal person's esophagus and stomach look like who don't have reflux. So the first question that the doctors ask is, well, how effective is this procedure? Like, okay, it's okay, you don't have to make incisions, it's not a surgery, you're just recreating the valve there to help prevent the reflux, but how effective is it? So each of these lines that you see in blue are a study, and when you kind of average them all out, 11 different studies, about 81% of patients are off of their PPIs completely. So patients that were previously on omeprazole or Nexium, about 81% of them are off completely. And the rest that are still on are usually at much lower doses. Okay? When we're looking at, okay, well, how good is it at preventing damage to the esophagus? Someone mentioned a cancer is a concern. So, well, clearly if you cause more damage and irritation to the esophagus, you would think that that would increase your risk for eventually developing cancer. So if you have inflammation of the esophagus, how good is this procedure at healing that? And the answer is it's about 80%, and this was done over 6 studies, of patients who had inflammation of the esophagus had improvement.
Question.
Yeah.
I have Barrett's.
Mm-hmm.
So would that help the Barrett's then?
Yeah. So I'll talk about Barrett's in a second here. That's an important consideration. But the short answer is yes. But the long answer is coming. Okay. We actually have to treat the Barrett's first. All right. So when we're, a big part of what we're talking about beforehand is, how these symptoms are affecting your life, because a lot of people aren't satisfied with lifestyles and pills. So we like to get some information on, well, okay, if you have bad reflux, how bad is it? And you can say, well, it's real bad. Well, is it real bad or really, really bad? I'm like, well, it's really, really bad. And you're like, well, that doesn't really help us very much, does it? So we try to quantify it. So we ask a series of questions in a standardized form, and we have patients rate them on a 0 to 5 scale. So how bad was your heartburn? How bad was it when you were lying down? How bad is it when you're standing up? And so with this information, it gives us an idea of like how effective, or how bad was your reflux before, and how effective is our procedure after when we repeat the same survey. So this is an example of how well the procedure worked in terms of quality of life. So what you'll see is in the blue line is, well, how high were their reflux scores? So 5 was the worst symptoms, and 0 was no symptoms. So with patients that have had the TIF procedure, at 2 years after the procedure, their scores went from between 45 to 50 down to less than 20. So significant improvement. And as time went on, at 10 years, it was about less than 10. And basically what that shows is symptoms were improved, quality of life was higher. We use tease that out to heartburn and regurgitation symptoms. So looking at each individual symptoms, it kind of shows the same thing. You had steady progression and improvement in quality of life. And that lasted for up to 10 years. This graph basically shows the same thing. It asks each of the individual questions. So for instance, how bad was your chest pain, or how bad was your regurgitation, or how bad was your heartburn? And in the blue, that high bar is how bad things were before the procedure. And the higher the number, the worse it is. And then what you see in the red bar, which is the next one down, which kind of drops off, is how are your symptoms at 6 months after? And then the next bar is at 12 months after, and then the next bar is at 59 months after. So over a period of time, it seems to be a fairly durable option to give you, sustained symptom improvement. Okay, this one shows basically the same thing with a different study that was done at 1 year looking at heartburn. So again, you see the kind of the same trends. Each of these different questions. Do you have difficulty swallowing, or do you have pain with swallowing, or do you have regurgitation when lying down? You saw improvements in all those things, and it's lasted, at least in this study, for over 1 year. Okay. I just wanted to emphasize one more study. This is called the TEMPO study. And this was an interesting study. It had 63 patients with reflux, and they divided them into two arms. Some people got the procedure, and some people stayed on the medication. Okay? And at 6 months, 90% of the people who got the procedure were completely off of their medications and not having any symptoms of reflux. All right? After 6 months, the people in the medication group who didn't get the procedure were given the option, well, do you want to get the procedure? And every single patient in the medication group opted for the procedure. So at 5 years, regurgitation symptoms were eliminated in 80% of the patients. At 5 years, most of the patients were off of PPI, so about 34% of patients were on PPIs. Everybody else were completely off. But when you look at who was still on the medications, they're all on much lower doses. So when we're concerned about long-term side effects like osteoporosis or concern for cancer, it stands to reason the lower the dose, the less likelihood you are to have the long-term, complications or side effects. And so the vast majority get off the medications completely, but even for the ones that don't get off completely, they're still on lower doses. So it did still derive some benefit. So this is just kind of a summary of some of that data. About 80% of patients come off of their medications. 84% had healing of the inflammation of the esophagus. About 81% had significant improvements in their quality of life. And patient satisfaction was about 76% overall. So to get the procedure, there's a long checklist of things that we need to do. There's certain requirements that need to be made, and that's kind of what this slide shows. In general, we recommend that patients be over 18. This isn't a pediatric procedure. And honestly, probably usually our target group of patients are going to be older because you've tried the lifestyle modifications, you tried the medications, and over time, these are the patients that we're trying to target when everything else before hasn't really worked. And again, it requires a long list of evaluations and studies in order to know that you're ready for surgery or for the procedure. There's a few contraindications, okay? So there's a few conditions that would prohibit us from doing a procedure. The first one, is probably the most important, is having a high BMI. So a BMI of greater than 35. That's significant because, again, the first thing, a lifestyle modification to help you get rid of reflux is to lose weight, okay? And this kind of dovetails nicely because I also do weight loss surgeries, and what I can tell you is doing a weight loss surgery, if being overweight is the problem, is going to be way more beneficial because we're dealing with both the weight loss and the reflux, okay? But for patients with a BMI of less than 35 who are just dealing with the reflux, this is a very nice option, okay? A hiatal hernia over 2 centimeters is something that, so again, if you have a stomach sliding above the diaphragm, we're going to have to, you may not be a candidate for the procedure that's just through the mouth, the TIF procedure. Okay, if you have a larger hernia, that may exclude you from just doing a TIF procedure. If you have Barrett's esophagitis, or severe inflammation of your esophagus, which you were asking me about before, then you can't get the procedure. However, if we treat the Barrett's first and we clear that out, then you would be a candidate for the procedure.
My Barrett's is stable.
Yeah. So usually we try to eradicate it with the procedure, like an ablation procedure, and we can talk about that more afterwards. But then it is appropriate, once we treat the Barrett's, to get it treated so that you prevent further acid exposure and damage. Okay. So I had mentioned if you have a hiatal hernia greater than 2 centimeters, you can't get the TIF procedure. Okay, and a lot of patients with bad reflux, the reason they have the reflux is because their stomach is bulging above the esophagus, and so their valve isn't working. Okay. So in those cases, what I'll frequently do is what's called a hybrid TIF. Okay. So what's nice about the hybrid TIF is it still fixes all the problems. It doesn't overfix them. Like with the Nissen, and for a lot of patients it works well, but it does require a surgery to fix the hiatal hernia. So the surgery would be through small incisions, laparoscopically, and I do it with a robot, but it does require a surgical procedure. And what that looks like is basically I bring the stomach down, and then I tighten up the diaphragm, the muscles of the diaphragm, so that they're closed more snugly around the esophagus. Okay? And then once that portion of the procedure is done, then I immediately do the TIF procedure that's done through the mouth. And again, in the same fashion, the scope goes down and I form a new valve. And that's what you see on the right there. All right, so in summary, GERD is an extremely common condition, but as you can see, it gets a little bit complicated in how we can go about the best treatment options. The options for treatment, vary from lifestyle changes to medications, but what I hope to leave you with at least is that there's some options that fall short of the old surgeries. We're kind of expanding what we can address, with safe means that are less invasive, that can treat the problem, that can get patients off of medications and help kind of alleviate their symptoms. And then the TIF is one such option that offers a less invasive option that has good results, that results in high patient satisfaction. So with that, I'm happy to answer any questions. We got a couple. Yes, sir.
As you showed there's a lot of testing that needs to go on. The question then would be, should I just do the wrapping rather than the TIF?
Mm-hmm.
Because if you do the TIF schedule of questions and answers, you would have to redo it in order to do the wrapping one, which is the full GERDs or whatever you call it.
So the workup for both procedures is the same, and it's necessary for both. In some cases, I might recommend the full wrap, the Nissen, depending on how things look and how severe the reflux was. But what's nice about the TIF procedure is if we did the TIF and say it didn't work or it wasn't, over time, say 5 or 10 years later, you start having more reflux again, we can repeat the TIF procedure if the valve is not working again. Or if you still need more than just that, you could still do the full wrap. It doesn't burn any bridges. It's just less invasive and with fewer side effects.
Do you do both?
I do both.
You do both?
I do, yeah. And I think it's important for doctors who are treating reflux, I think it's important to look at the whole spectrum of options. So rather than just push one option, right, I think it's better to have all available options to get the right fix for the right patient. Yeah, so I do both, and I think you kind of should have to, I think it's better when the provider can do all the procedures. That way they're not biased towards one and will do the wrong procedure on you when you should have had a different one. Yeah?
What's the frequency with which you do the TIF procedure?
The frequency? So we just started. So we've done in the last year, or the last let's see, in the last month that we did them, we did about 4. We have 1 for this month, and I have several that are in the works. But I do hiatal hernia repairs quite frequently in my weight loss. So with those, we're doing anywhere between 5 and 15 a month. Yeah.
How would you proceed with someone who has had the Whipple procedure?
A Whipple procedure? Cautiously. No, that shouldn't be a problem at all, especially if it was just the TIF procedure without need for additional surgery. That actually might be advantageous because we're avoiding having to go through the abdominal cavity, which may have scar tissue, and just doing everything through the mouth. But we'd have to see if you're a candidate for that.
I was going to say, I assume I have this with the whole book.
Yeah.
Find out how I put together.
Right. Yeah.
You have to have a referral to you.
No, you can give us a call. Our information will be out there. Yeah.
I couldn't, when you showed the TIF procedure up there, I couldn't really read it very well. And I saw you have this, this mechanism that you put down the esophagus. Is that stay there, or is that just used to create the whatever you do?
So we fire what are called H fasteners. They're basically plastic polypropylene, and those are similar to other types of suture material that we use, and those stay in place, but your body tissues actually fuse together. Okay, so they're holding it in place. They stay there. They don't come out, but those little purple things that I showed, those stay there. They'll get overgrown over time, but everything else comes out, and it scars in that way. Yeah. Yeah.
You said if you got Barrett's, you got to treat that first. What's the treatment for Barrett's?
So for the treatment for Barrett's, there's a couple of different options. A lot of it's basically to ablate the Barrett, so basically to burn it off and allow new cells to grow on. For that, we don't offer that here, but I have a few good people to refer to get the Barrett's cleared out.
Okay. I have both. I have hiatal and Barrett's.
Yeah.
Where would you start, the Barrett's?
I would start with the Barrett's and then fix the hiatal hernia. And then we'll talk about wrap versus TIF versus, yeah. Yeah.
Is it unusual for a person to have a hiatal hernia taken care of and then develop another one in a very short time?
No, that's actually not unusual. That can happen, and it kind of depends. Not all hiatal hernias are created equally. Smaller ones tend to be less of a problem in terms of coming back. Larger ones where you have if you have the majority of the stomach in the chest cavity or other organs like the colon in the chest cavity, those have a very high rate of recurring. If we're talking about kind of a smaller hernia where the stomach just slides up, those tend to be less likely to come back. And those tend to be the majority of patients who would get these repairs with a TIF. Those would be smaller hernias that are less likely to come back. But if you have a large hernia, that's been a big kind of quandary for surgeons to get those fixed and get them to stay fixed. The good news is when they do come back, they tend to be that cause less symptoms. But yeah, there's a lot of tips and tricks for how to keep that hernia from coming back when it's a large one. Okay.
Is that something you can take care of the second time?
That's something we could talk about. The second time is always more challenging because there's scar tissue, and that scar tissue is in kind of high-priced real estate around the heart and lungs and vessels. So, yeah.
Assuming good health otherwise, is age a factor in the success of the surgery?
Age is always going to be somewhat of a factor. In some regard, if your health is good, it shouldn't be a huge factor, but it certainly can affect healing. Undergoing a surgery where there's incisions as opposed to doing a procedure where we go just through the mouth, certainly the procedure through the mouth is going to be much less invasive and much easier to recover from overall. So when you're talking about just, age, what you're really talking about is general kind of medical wellness or what we call, fitness. how well you would recover, because someone who could, undergo a big surgery and recover pretty quickly when they're younger, at an older age, they can undergo the surgery and they're in pretty good health maybe even, but the recovery is going to be longer. And
But as far as the success of the procedure,
as far as the success of the procedure, yes, I think you'd be just as successful. The long-term concern with the procedure is like, well, how long is this going to last me? Like, okay, well, it lasts 10 years, but then what about after that? And it's kind of like, well, it's kind of like a knee replacement. You don't expect it to last forever. So in some regard, if you get it, kind of as you're aging, then dealing with long-term complications is less and less of a risk. And I think that's partly why we're seeing an uptick in like patients over 65 getting surgery procedures for reflux, because they want to get off the medication. They're more concerned about developing dementia, for instance, when they see that. And while you could say some studies show that after 10 years they might, patients might start having issues with the repairs or the anti-reflux procedures not working as well as they used to. Typically that's not such a big deal if you got 10 good years out of it. So for instance, I had a pharmacist in my clinic several years ago who had a Nissen Fundoplication, but it was starting to come undone a little bit, and he started to have some reflux. And he's a pharmacist. But so he came to my office and he said, well, can you just go back in and tighten it up, do it again? And so I said, well, that's major surgery. There's some scar tissue. And he said, yeah. And so, but when I was talking to him, I was impressed with that. Even though you could say, if you were to read this in an article, you consider that, well, his surgery failed. But when I talked to him, like, well, are symptoms better than what you had before the surgery? He said, oh yeah, they're way better. And like he wanted more surgery. So in the literature, that would have been, written up as a failure of surgery. But when you talk to the guy, he's like, no, I want more surgery. That worked really well the last time. I just need to get a tune-up, right? So it's kind of interesting when I read some studies and I look at the literature, a lot of times they say, well, surgery doesn't work that much. And only 80% got off their PPIs, not 100%, so it's not worth it. I'm like, well, that's pretty high. That's a pretty high bar to set. And when you talk to patients, like, well, yeah, I'm back on my PPI, but it's only once a day, and it's a much lower dose, and I can handle it. I'm still happy. I'm so glad I got the procedure, which is interesting because if they were just a stat, in a paper, they'd be in the failure group. But when you talk to them, like, oh no, I'm glad I got the procedure. So that's interesting.